is classically described, the middle ear is a four-walled room having the roof and the floor. So we will see the features in all the six walls. The middle ear is an air-filled cavity which is sandwiched between the internal ear and the external ear. So that part is the middle ear, and it is further subdivided into three components. The part parallel with the tympanic membrane, this is called as mesotympanum, and the part above that is epitympanum, and part below that is the hypotympanum. This is the schematic figure showing the shape of the middle ear cavity, which is a biconcave disc, just like an RBC. So it is narrow in the center, whereas at the peripheries it is wider. Here is its posterior wall, which is the largest wall. So let us see each of these walls one by one, starting with the lateral wall. The lateral wall consists of two parts basically. It has a bony part and the membranous part. So the membranous part is formed by this tympanic membrane here. You can see the handle of the malleus on the tympanic membrane, and which is related to the chorda tympani nerve here on its medial aspect. That's the posterior canaliculi through which this branch emerges. And the bony part is formed by here the outer wall of the epitympanum. We'll see some more details of this bony part in the next slide. Few more things at the medial end of the petrotympanic fissure. There are two canaliculi, one for the anterior ligament of the malleus and another one for the chorda tympani. That's the anterior canaliculi of the chorda tympani, through which it passes and enters the infratemporal fossa. If in this view, this figure shows the middle ear cavity from the external auditory canal. The tympanic membrane has been cut open, whereas this figure, the anterior wall has been cut open. That's the lateral wall and that's the medial wall, and this is the posterior wall. So the anterior wall has been cut open and we are seeing these features. Let us see some more bony parts in the lateral wall. We will continue with that. This scutum, and these are the other bony parts which we will see. The outer wall of the epitympanum, if this is the outer wall of the epitympanum, meets with the superior wall of the external auditory canal, and this sharp bony spur is formed. This is called as the scutum, which is shown here in this CT, where this is the external auditory canal, and this arrow, the white arrowhead here, is showing the outer wall of the epitympanum. This is the epitympanum here, having the head of the malleus and the body of the incus. So this projected part is the scutum. And the tympanic ring, this is C-shaped ring present at the medial-most part of the tympanic bone. So this is C-shaped ring, so this is deficient superiorly, and this deficient part is called as notch of Rivinus. Notch of Rivinus, and it is deficient on the superior aspect, the tympanic ring, anteriorly and posteriorly. So the anterior, this part, this is called as the anterior tympanic spine, where it ends anteriorly, and this is the posterior tympanic. These structures give attachment to the pars flaccida part of the tympanic membrane, whereas the tympanic ring gives attachment to the tympanic membrane, the other part of the tympanic membrane, the pars tensa. And medial to the tympanic ring is the tympanic sulcus, which holds the annulus of the tympanic membrane. So this is the endoscopic view of the lateral wall, where you can see the annulus here of the tympanic membrane. This and these two structures are the anterior and posterior tympanic spine, and that is the notch of the venous where the pars flaccida is attached, and this projected part, what is shown here with S, that is the scatum. This is another figure of the lateral wall showing the petrotympanic fissure. You can see here, and at its medial end there are two canaliculi, the Glaserian for the anterior ligament of the malleus, which gets attached to the spine of the sphenoid bone, and there is canal of Hagiur. This is the anterior canaliculi for the chorda tympani. Pardon me if I did not pronounce these terms appropriately. I am not familiar with these terms because these terms are not described in anatomy textbooks. And here you can see the posterior canaliculi. We will also see this when we discuss the posterior wall. You can also see here the posterior tympanic spine. So that's about the lateral wall of the middle ear. Let's move to the inferior wall. The main features what we see is the jugular fossa and the opening for the tympanic branch of the glossopharyngeal nerve. So let's see this figure. Here the lateral wall has been cut open to show the interior of the middle ear. Here is the jugular fossa, where the superior bulb of the internojugular vein is present, and that's the lower end of the carotid canal. And in between these two structures there is a tiny opening from which the tympanic branch of the glossopharyngeal nerve, which is also called as the Jacobson's nerve, passes through it and enters the middle ear cavity. Below this will be the inferior ganglion of the glossopharyngeal nerve, from which this tympanic branch will arise, and it enters the middle ear cavity through this canaliculi. And it is around 2 millimeter in front of the niche of the round window, and over the promontory it forms the tympanic plexus. This nerve carries the preganglionic parasympathetic fibers for the parotid gland, and it has a sensory supply for the middle ear cavity. It is another figure just to show the same thing what I have described here. That's the jugular bulb, and that's the carotid canal, the lower opening of the carotid canal, and here is the inferior ganglion of the glossopharyngeal nerve, giving the Jacobson's nerve entering the tympanic cavity. And this is where the round window is. So this nerve lies anterior to that. And that's the promontory where the tympanic, and this nerve is taking part in formation of tympanic plexus. Anterior wall, as in the lower part, has a carotid canal. You can see here, this is the carotid canal through which the internal carotid artery will pass. Along with the internal carotid artery, there is sympathetic plexus. So this sympathetic plexus will give two nerves, the superior and inferior caroticotympanic nerves, along with the vessels. So there are openings not shown in this figure. There are openings through which these two nerves and vessels will enter the middle ear cavity, and these nerves will also take part in formation of the tympanic plexus. In the upper part of the anterior wall, there are two canals, one for the auditory tube and another one for the tensor tympani muscle. So these are the features in the anterior wall. Let's move to the posterior wall. This figure, what is seen, the anterior wall has been opened. Here is the lateral wall, here is the medial wall, and this is the posterior wall. So the features seen here, that is the auditus, which is the communication between the middle ear cavity and the mastoid air cells. Here is the fossa incudis, where the ligament for the short process of the incus is attached. We also see the canal for the facial nerve, and then this elevated part is the pyramidal process. Inside the pyramidal process is the stapedius muscle and its nerve supply, which comes from the facial nerve, and there is a tiny opening at the tip of this projected part, through which the tendon of the stapedius comes out and gets attached to the neck of the stapes muscle, the stapes bone here. So that's the pyramidal process. Here, this is the caudal eminence, lying lateral to the pyramidal eminence. It has the opening for the posterior canaliculi of the cauda tympani nerve. This elevated part lies at the junction of the posterior wall and the lateral wall. Apart from, here is another figure to show the canal for the facial nerve, which has been opened here. That's the facial nerve. That's the pyramidal process. That's the caudal eminence. You can also see the cauda tympani nerve passing through it. Apart from this, the posterior wall also shows several bony ridges and one more eminence there, the styloid eminence. This is the picture, endoscopic figure. That's the styloid eminence, and these are the bony ridges, the caudal ridge of Proctor, which is between the pyramidal eminence and the caudal eminence, the pyramidal ridge, which is connecting the base of the pyramidal eminence to the styloid eminence, the styloid ridge connecting the styloid eminence to the caudal eminence. Then there is ponticulus from the pyramidal process to the promontory, subiculum, which is present behind the promontory from the posterior lip of the round window towards the styloid eminence. Then there is first is a thick bony projection between the basal turn of the cochlea and the styloid eminence. You can see it here. And there is funiculus from the anterior pillar of the round window to the hypotympanum. That's the funiculus. So these are some more structures seen in the posterior wall. Apart from this, some more spaces are there around the facial nerve. The two lateral and two medial spaces, which are the two lateral ones are the facial sinus, and the lateral tympanic sinus, and the two medial ones are the posterior tympanic sinus and sinus tympani. That's about the posterior wall. Let us see the superior wall, which is called as the tegment tympani. And another important bony structure seen here is the cog. So let us see the formation of the superior wall, what constitutes the superior wall. So there is, let's get oriented, that's the anterior end, that's the posterior end. It is formed by the tegmental plate of the petrous bone, petrous part of the temporal bone, meets with the horizontal plate of the squamous bone, and at the petrosquamous suture. They meet at the petrosquamous suture. So that's the tegment tympani. And cog is a transverse prominent crest located at the anterior end of the horizontal plate of the squamous bone. It lies anterior to the head of the malleus. Apart from this, in this figure, you can see there are openings for greater and the lesser petrosal nerve in the superior wall of the middle ear cavity. Medial wall. This figure shows the medial wall as the lateral wall has been removed here. So the features seen in the medial wall, an elevated part, the promontory, which is formed by the basal turn of the cochlea, over which lies the tympanic plexus. Now, above and behind and above, here this is the oval window, which is closed by the foot plate of the stapes bone, and below and behind is the round window. The medial wall also shows the oblique part of the facial nerve. This what is shown here. That's the facial nerve, the bend there. And it also has the bony projected part, the processus trochleoformis, where the tensor tympani muscle changes its direction and gets inserted to the handle of the malleus. Few details about the ear ossicles. The malleus incus and the stapes. The malleus has a head, neck. It has an anterior process as described earlier, gives attachment attached to the anterior ligament of the malleus, which passes through the medial end of the petrotympanic fissure and gets attached to the spine of the sphenoid. It has the handle, which is in contact with the tympanic membrane. Its upper end of the handle gives attachment to the tensor tympani muscle, and medially it is related to the cauda tympani nerve. The head of the malleus gets articulates with the body of the incus. So parts of the incus are the body, the short process, and the long process. The long process lies parallel to the handle of the malleus, and its lower end turns medially to articulate with the head of the stapes bone. Coming to the stapes bone, it has a head. That's the head there, and that's the narrow neck, which gets attachment to the stapedius muscle. And it has two crura, the anterior crus and the posterior crus, which is attached to the foot plate or the base of the stapes. This base gets attached to the oval window through the annular ligament. These are the references for my presentation. I thank my ENT department for inviting me for this presentation. I thank Dr. Utkal Mishra for helping me out with the content. There are certain things which are not described in anatomy textbooks, so it was a learning experience for me also. Once again, I thank the ENT department for giving me this opportunity.
Thank you, Dr. Brijesh. Thank you very much, and it was very much understandable presentation, and it really, I think all the delegates must have understood the three-dimensional anatomy of the middle ear cavity and how the orientation of various structures are there, and they would certainly use it for their further surgical clinical practice. So now next we'll move onward with the presentation of Professor Virk. Dr. Virk is from PGI Chandigarh, and he has a very special interest in this stapes surgery. So we all have learned from him a lot. In fact, people who have been outside the PGI have also learned from him. So, sir, I think we should start with your presentation and let's.
Right. Thank you, Vikas. So let me see how to get the window up.
Okay. Sir, the third button, fourth button from the right.
Yep. It's not.
Sir, in your screen there is mic, then there is camera.
So can you see the screen?
No.
Okay. So it's still not sharing. That means.
Yes.
Sir, Brijesh sir's screen is still sharing. That's why it is not happening
Acha.
like this.
Okay. Dr.
Okay.
Brijesh. हाँ.
Okay.
Yes. सर अभी करिए सर आई थिंक अब आ जाएगा.
My fourth button can't be highlighted actually.
Sir, try now.
Nope, it's blanked out. Okay, so let's try again. Is it sharing now? All right, so you can hear me and you can see me, that's correct?
Yes, sir. Yes, sir.
If I say present now, it shows me an option, your entire screen or a window.
Window.
Let's hit a
Sir,
window.
your PowerPoint should be not be minimized.
No, it's not minimized.
So when you click on the window, it will show PPT. So you should select the PPT.
Okay, so it says allow me.google to see your screen. It says mail module
Window.
So should I click on Microsoft PowerPoint?
Yes, sir.
No. Is it sharing now? There's something with
कोई नहीं
that.
सर आप एक काम कर सकते हैं सर इंटायर स्क्रीन करिए फिर बस ये है कि you will not be visible. Your screen will be shared. That's the easiest way
So
to do.
let's take your entire screen. Again, it asked me select window.
Yes, sir. You have to touch on that area. Entire screen में जाके सर वो ऊपर आपको एक बार क्लिक करना पड़ेगा.
So my presentation is on full screen.
नहीं सर वो जहाँ से आपने present now करा है वहाँ पे it shows ना. When you will select entire screen, then you have to go right upper corner where it is showing the screen. Whatever it is showing, you have to click on that.
Okay, so let me try once again. I'm sorry, guys.
No,
This
no
Google
issues.
Meet is always.
Yes, sir, there are so many platforms now we use, तो इसलिए
तो मेरी स्क्रीन तो यार पावर पॉइंट तो पूरा चल रहा है. ओके, सॉरी नाराकट, कांट शेयर योर स्क्रीन.
अच्छा कांट शेयर ये उससे ये थोड़ा सा सर ये इसका इशू होता है आपका एप्पल है ना सर. लास्ट मोनिश का संग भी ये हो रहा था इशू. मैं पूछता हूँ. आ गया सर, आ गया आ गया.
आ गया. ओके.
स्टॉप.
नाउ आई हैव टू.
नहीं नहीं सर वो
ये क्या आ गया?
ये सर क्या है कि आपके स्क्रीन में जो दिख रहा है ना वही बार बार दिख रहा है वो अल्टीमेटली. यस उस वाले स्क्रीन को सर मिनिमाइज करना है आपको. ये वाला जो स्क्रीन अभी खुला हुआ है प्रेजेंटेशन शुरू करके इस स्क्रीन को सर ऊपर से जाके राइट अपर कॉर्नर से मिनिमाइज कर दीजिए और आपके स्क्रीन में बस पीपीटी आना चाहिए. देन इट विल शो दैट ओनली.
ओके. हाउ इज इट शोइंग?
सर आ रहा है बस. अभी सर मिनिमाइज कर दीजिए उसको आप अपने स्क्रीन को.
उसको तो कर दिया मिनिमाइज.
नहीं वही आपका सर वही दिखा रहा है एक्चुअली. आपके
व्हाट इज इट?
आपके स्क्रीन पे सर सिर्फ पीपीटी दिखना चाहिए. आपके स्क्रीन पे आपको.
पीपीटी देख रहा है सिर्फ.
अच्छा फिर कहाँ गया प्रेजेंटेशन? डॉक्टर उत्कल.
Entire screen says you are presenting. Okay, so maybe इधर से ऐसे कर लेते हैं.
आपका स्क्रीन
अब आ रहा है? अब आ रहा है? अब नहीं आ रहा. So that means there's something else has to be done in probably settings or something. Oh God. We'll try again. Rent a window. Hold on. अभी भी नहीं आ रहा. अब तो it shows you are sharing the PowerPoint. नहीं उससे नहीं होगा. I can try. Hold on. Okay, there we go. So, वही मैंने किया. ओके, सो आई प्रेजेंट शेयर योर स्क्रीन. योर एंटायर स्क्रीन या विंडो? विंडो किया. विंडो में मॉड्यूल कर दिया. ठीक है, पर जब वो अलाउ करता हूँ तो इट सेज यू आर प्रेजेंटिंग योर स्क्रीन. वो इन्फिनिटी एरर आ गया ना। क्योंकि ये गूगल खुला ही ब्राउजर में है ना, तो देयर इज अ ओके, वन सेकेंड। Mohnish tha, he was trying to, he said he also had the similar problem. I'm going to try once again, present a window, PowerPoint, allow. अभी भी नहीं शेयर कर रहा। जब मैं क्लिक करता हूँ मेरे उधर स्क्रीन पे CO2 स्टेप डॉट में ही आ जाता है, and either it's showing that it's sharing. What do we do now? Yeah. Let me see. So I think it's info. 4 GB का है, तो आई थिंक जाएगा भी नहीं। तो मोनीश इज सेइंग रीस्टार्ट करके देखो कंप्यूटर, सो कैन आई डू दैट? So just okay.
Hello. So hi everyone. Till the time Dr. Virk is joining us back. So if you people have any queries or anything, any confusion in your mind which you find it difficult to understand, then we can discuss those things. Or what I would suggest is that at whatever stage of learning or stage of your clinical practice you are, it is always important to, when you are seeing the middle year, and most of the time what happens, yes, Dr. Virendra is okay, references. Okay, we will ask Dr. Brajesh to show the references again. So, a book which, soft copy of the book which we have shared, Dr. Utkal has shared in the group. I would request all of you to please take printout of that book. Okay, because that is a very basic book. So when I was like resident initially, what happens is that you will always be, when if you are a trainee, during whether you are a PG postgraduate resident or you are a senior resident, uh, the most of your time is when an ear surgery is being done. Our time is spent on the watering part. So we are asked to keep on that water flowing when our senior is drilling. And for initial, for my few months, I was like, okay, I am just watering the surgery, and I'm unable to understand that what is the special orientation of various structures, and why the drilling in the way it is being done, why it is being done like that. The parts which the part which are addressed first, why they are addressed first, the part which are addressed at the last, why they are addressed at the last. So this basic book is for that purpose only. It will very nicely make you understand that what is the special orientation, where your dura will be, how dura will come closer as, or come medial, or your area of drilling as you go from lateral to medial, how the spaces are oriented in the middle ear cavity or the mastoid cavity, where your facial nerve will be, where your little semicircular canal will be. So I would request that every time you are assisting, or in fact, if you are, whenever you are doing an ear surgery, especially the mastoid surgery, you should be reading this book once before you go to the OT next day, and then when you come back, you again read this book, see the references, and it very well tells you that what are the different types of mastoidectomies, and about various things.
Okay, so I changed the privacy settings. I just Googled that. So let's see if we can.
Sir,
Okay, can we see them now?
I
Prakash?
think yes, yes, sir, yes, sir, yes, sir,
Great. So should we start?
yes, sir.
Sorry everyone for the delay.
You can maximize this, sir.
Huh? Okay, I just need to know if you guys can hear and see me. Great. Um, Okay, so good morning, everybody. Sorry for the little delay, just technology hiccups, but we finally figured it out. I'm Ramandeep Virk. I'm an ENT surgeon at the PGI Chandigarh, and I will be speaking upon a very specific topic today, carbon dioxide assisted laser stapedotomy. We will touch a few points on what is important in the workup and history taking, the size of the prosthesis, the prosthesis, etc. So my journey would not be, complete without these two people. So on the left, this is Professor Arjun Das. He was my mentor and guide, and he was the first person that he was my boss actually while I was doing my senior residency, and he was the first person who gave me, a stapedotomy to do. He scrubbed for the entire case, stood behind me, and made me do the stapedotomy. So that's where my journey started, and he made me do it with a skeeter, even though he used to do it with conventional instrumentation. He was a visionary as far as I would say, and he told me that skeeter is going to be the way forward. So it's better you learn with this. So that's how my journey started. Next picture, everyone would recognize the person. It's Satish Jan. He was the one who introduced me to the world of lasers. They taught me, and that was 2010 or 11. He had got his new luminous laser. I had gone to him, and he made me do about 8 to 10 cases. Came back to PGI, we ordered our laser. We got a laser in 2012 or 13, and since that time, I've just done laser stapetotomy. So when a case of autosclerosis or autospongiosis does come to you, we have to take a detailed history. Of course, it's very important. Evaluation. So evaluation is not just to further, strengthen your diagnosis, but also like you are a new surgeon who is just starting out to do a stapetotomy. You need to evaluate how big the canal is, whether you will be easily able to access the anatomy. Because when you start out, you want to start out with simpler cases. Leave the complicated cases for later on. Everyone's time will come. It's a journey which everyone has to complete. Then CT scan is mandatory, like I do it in all my cases, and we will soon discuss why. And then, of course,
Sir, slide change नहीं हो रहा sir. Slide.
Which slide are we on?
We are on the first slide.
Yes, sir. Same here, sir.
Now?
अभी तो सर फर्स्ट ही है. You can click on the fourth or fifth slide, sir.
नहीं, मैं फोर्थ स्लाइड पे हूँ. राइट शो ऑफ कर देना. Now is it changing? I am मेरी स्क्रीन पे तो नंबर 2 ही दिखा रही है.
Okay.
Okay, I'm going to go through it again. अब no, are the slides being changed?
सर लेफ्ट साइड में ग्रिड व्यू आ रहा है स्लाइड्स का.
But I can't.
Second, sir.
So I can't click the second slide.
Okay. एक बार सर इंटायर स्क्रीन करके देखिए शायद तो.
अब देखना.
अब चेंज हो रहा है सर. यस सर.
Okay.
यस सर.
So this I've already spoken about this slide. So on my left is Professor Arjun Das, on the right is Satish. So what will we be touching on? We'll be touching on role of CT, medical therapy, brief on the size of fenestra and piston, procedure with the laser, and the complicated cases I've encountered and the special situations. Knowing about complications is very important, and knowing where your limit is also very important. That आपने कहाँ रुकना है और कहाँ you can move on. So literature again is full of pluses and minuses of doing a CT scan, but at our institute, I mean especially in my cases, we always get a CT scan done. The reason for that is it gives me an idea whether I'm encountering an obliterative focus, whether I'm encountering a low-lying facial nerve, and that actually helps us. So when you are beginning to do a stapedotomy, if you know these things in advance, you would not want to do an obliterative focus as your third or the fourth surgery. Once you are experienced, it is okay. You can go ahead, do an obliterative focus, drill it out. But these are all difficult situations which need a lot of clinical skills and expertise. So if you know that the facial nerve is not dehiscent or low-lying, the niche is not very narrow, there is no obliterative focus, it is easier for a beginner to do that case. So this was an article published in Otology Neurotology, and the conclusion of doing a CT was it was a systematic review, and it indicates that imaging has a useful role in both the diagnosis and management of autosclerosis. Okay. And this was another study published in the European Radiological Archives, and this concluded that the positive predictive value of CT diagnosis of autosclerosis was 100%. And this actually is true. Once you are able to see that little focus in the fistula antifenestrum, your eyes will get trained. You will pick up every case of autosclerosis on a CT. But it has to be seen on the DICOM. So what we do is we ask the patient to get the CD or email it to us, and we see it on our DICOM viewer. Okay, so this is how a autosclerosis would appear. So can you see this is the foot plate pointed by my pointer, and this lump of tissue is the autosclerotic focus. Do you see this bone? That is the autosclerotic focus. Same with the other ear. This is the autosclerotic focus, and this is the foot plate. Now this clearly tells us there is adequate space for us posteriorly to put the piston. But if this focus had completely obliterated this area, then it would have been difficult. That would be an obliterative focus. So this basically gives us an idea of the autosclerotic focus, confirms the diagnosis, and helps us to execute the surgery better. So this is another of my case. We had done a stapedotomy, and a few years the patient was okay, but then after 4-5 years she developed a conductive loss once again. So what we did, we got a CT scan done, and look what we found. Do you see this loop of piston outside the incus? So this was a displaced piston, and this corroborated with our findings when we opened up the case. The piston had moved out. It was attached to the posterior wall with adhesions, and there was slight necrosis of the incus. So we just put a spot of bone cement here, and we put a titanium prosthesis. We changed the prosthesis. So if I know pre-op what is happening, it gives me a certain peace of mind. It helps me perform the case better. It makes me know what to expect when I open up the case and how to prepare myself. Sodium fluoride, repeated studies in the past have showed there is no role. So let's stop teaching that sodium fluoride will stop the progress of the disease or will make it better. It will not. So we routinely do not prescribe sodium fluoride for the management of autosclerosis. And repeated studies, if you search the literature, there are adequate studies which show that it's a very low quality evidence that sodium fluoride may be of benefit to preserve hearing and reduce vestibular symptoms in patients with autosclerosis. Even other drugs, like many world over, I mean, they are trying an anti-osteoporotic drugs, corticosteroids, vitamin D administration. Again, literature has shown that it has no value. Now, choosing the type of prosthesis. When I started doing my stapedotomy, I used to use the Teflon prosthesis. Again, very cheap, works very well, easy to use, easy to replace. But then later on, I have shifted to the titanium prosthesis. So this is what I currently use. I find it, the reason I shifted to this was that I found it easier to work with. In the sense that many times, when you are a newcomer and you're trying to insert the prosthesis, it will hit some part of the middle ear, it becomes bent, it becomes crooked. That does not happen with this titanium prosthesis unless you use excessive force. Second part, in this prosthesis, the Teflon prosthesis, you have to insert it and hook it onto the incus in the same sitting. But with the titanium prosthesis, this titanium prosthesis has two loops. Okay, the front loop and the second loop, which finally clamps on to the incus. So what happens when you insert the prosthesis, in the first go, you put it in the stapedidotomy opening and just let this part, this first hook, hang over the incus, right? Once that is done, then you use a pick and you engage the pick in the posterior part and just push the titanium prosthesis onto the incus. So this I have found easier to work with, but that being said, the results of the two prostheses are not any different. So choose it when you start doing your stapes surgeries, choose according to whatever you are more comfortable with. So this was an article on the effects of fenestra size and piston diameter on the outcome of stapes surgeries for clinical autosclerosis. So in this, they have said that a small footplate fenestra has statistically significant advantages for hearing gain over all other sizes of fenestra. All other sizes would mean a stapedectomy, that is complete removal, a half removal, or a 1/3 removal. Many surgeons would remove half of the footplate. So a small fenestra created either with a conventional instrument, a skeeter, or a laser has better hearing outcomes, and small fenestras are recommended for surgery. And then the golden question, what, which every examiner asks the residents when they are going to pass out, and we get asked these questions all the time at all the conferences. Is 0.4 better? Is 0.6 better? 0.7 better? 0.8 better? So this was a study done by Lasky and published again in Otology Neurotology. If you read the article in detail, it will tell you that there is not much difference between a 0.4 and a 0.6 millimeter piston. The outcomes are the same. But for a conclusion, they have said that a 0.6 millimeter piston is kind of better than a 0.4 millimeter piston. I only use the 0.4 millimeter piston. Rarely would we use the 0.6 millimeter piston if the 0.4 is not available. Otherwise, for many years, I've just used the 0.4 millimeter pistons. So let's start with the carbon dioxide laser stapedidotomy. This we use the luminous aqua pulse duo machine, and in this micro manipulator, that is no touch technique, and it also has a fiber in which you can use a handheld fiber to perform a stapedidotomy. So what are the various steps? I will just go through the steps and then we will come to the videos. Infiltration of the EAC, I have shifted on to endoscopic. The view an endoscope gives you is phenomenal, and a single prick and an insertion of 2 ml, 1.5 ml of anesthetic is enough to blanch the complete EAC. So multiple pricks are avoided, and you can actually see the blanching take place completely. So you know that everything, the anesthesia is proper. Then a TM flap is elevated, the cauda is identified and preserved, the posterior superior overhang is drilled out or curated. Then we do the tenotomy, that is the vaporization of the stapedius tendon. That is done with a 14-watt setting of the laser. Then the posterior crurotomy is done with an 18-watt, and then the fenestra is made with a 20 to 22 watt of laser power. So when I'm using a 0.4 millimeter piston, I use a 0.5 millimeter fenestra. If I'm using a 0.6 millimeter piston, I will use 7 millimeter fenestra. If the footplate is thick or obliterative, then laser will not go through the obliterative focus. You have to drill it out, blue line it, and then fire your shot. And then the titanium prosthesis is inserted. I do not seal the fenestra which we have made. It will, a neomembrane will form, start forming in a few days, and that's all that is needed. So this is the infiltration. This is the left ear. Notice posterior superiorly, I insert the needle, I feel the bone, and I start infiltrating gradually. And see how the anesthetic agent is moving forward. And you can see the posterior superior part blanching, and you will soon notice all this will become pure white as the anesthetic will travel all around the canal. So a single prick will give you a 360-degree anesthesia. So just look how everything has blanched out. And this with a minimal single prick and a minimal use of 1.5 ml of anesthetic. Okay, so now we come to the procedure. Now this is the right ear. Okay, you can see the incus, you can see the stapedius tendon, you can see the blue foot plate, you can see the facial nerve, and you can see the posterior crura peeking out from here. So again, using we will do a tenotomy with a 14-watt shot. There. So the shot is fired and the tenotomy is done. Then when I fire on the crura, I fill the foot plate with gel foam and I fire the shot on the posterior crura. Once that is done, we fracture it out, the interior part, and remove it. And that's the shot which is fired on the foot plate. A nice round shot which has been fired. This is the titanium prosthesis, as you can see. We take it and we gently open it. This is very important. If you see that the incus is thicker, open it nicely. Otherwise, once you try to push it onto the incus, it will not latch. So I put it in the fenestra and let the front hook engage it without attempting to put it. Then I take a pick, insert it in the notch which is at the back, and then push it onto the incus. So the seal is already perfect. There is no leak of any perilymph, no fat or anything is inserted in the foot plate, and we deposit the tympanomeatal flap. I don't pack the ear. I just take a piece of gel foam and keep it here. That's just a single piece of gel foam. For the incision, this is the left ear we are operating. I make a radial incision outwards rather than that typical C-shaped incision. And then I join it with a circular knife and take it superiorly. The reason I do this is many times the canal wall is thin, or during your anesthesia, you have created blebs which make it thin. If I make a radial incision, I can bring it outwards till the point I encounter a thickish tympanomeatal flap. Then using a small cottonoid or a gel foam, we elevate the tympanomeatal flap. We lift up the annulus. You can see the blue mucosa of the middle ear which has come into view. The posterior superior part, many times there is tenting of it. So using a sharp scissor, you just cut it. After that, using a pick, we enter the middle ear space. And you can see the round window. You can see the promontory at the moment. Any adhesions or any part of tenting that is taken care with a Plester's knife, make sure you move it forward. And then we just keep a small piece of cotton or gel foam to keep the flap positioned anteriorly and out of your way. Now I can see the incus, I can see the stapedius tendon. Next is we handle the chorda tympani. So gently take it out. And I make it touch the flap. So once it touches the tympanomeatal flap, it just sticks to the flap and it is out of your way. So not too much stretching, not too much pushing, pulling, cutting. It is just sticking to the flap. So once the curating has been done, I do a tenotomy. Then, like I said, once I work on the crura, I will put a piece of gel foam into the foot plate area so that laser does not spill over. Fire a shot and there, the posterior crura gets cut. Gently pull it out. And then we fire a shot in the foot plate. And then we insert the piston. So I'll go into zoom. Do you see how nice and circular the laser shot makes this opening to be? Right? And this area, can you see this whitish area? This is the fistula antifenestrum. This is where the autosclerotic focus is. Otherwise, the footplate is nice and blue. This is the pyramid. And then you just insert the piston. So again, we are using a titanium piston. In the first go, put it into the opening and let the front hook hang on to the incus. There, we don't try to then either with a pick like I had shown in the previous case or with a fine forceps. I just hold the posterior end and lock it over the second loop of the titanium prosthesis. Again, no fat, nothing is sealed. And that completes the procedure. So now the advantage of this AccuPulse Duo is that we can also use a fiber. That's a handheld fiber. And in this case, just for demonstration purposes, we were using a fiber. I am happy using the micro manipulator. Those who use the fiber also perform the surgery to perfection. So it is just more a matter of a personal preference. For me, kind of working in high magnification and with the age all of us are hitting, that is near 50, I can see the tremors when I am holding a handheld probe. But with a micro manipulator, the tremors go away. So this case had a dehiscent facial nerve. You can see I'm checking it with a pick and how I can press it away. And it was a low-lying dehiscent facial nerve. So I'm using a handheld probe and a 1 watt power. I'm going to vaporize the tendon. So you just fire a shot or 2 shots and the tendon vaporizes. Again, the same procedure and protocol is followed. Once you are working on the posterior crura, put a piece of gel foam into the foot plate so that if there is any spillage of laser, it does not go through the foot plate. Now you can see the crura. And I fire a few shots onto the posterior crura. There needs to be some gap between the fiber and the crura. Don't, rub the fiber onto the bone. So we weaken it with a few shots. Once it is weakened, it's like it just breaks with the pressure. It just disintegrates, shatters. So using a pick, see, it's already gently push it towards the promontory. And take it out. Now we will work on the foot plate. You can see the blue foot plate. And I use a 2 watt power. And a fenestra is created. Now the problem with the handheld laser is that it is not a single shot like with the micro manipulator. Once you have created that opening, you need to make it circular with a instrument. The reason I don't like is that it does not make it a non-touch technique. And in this case, we were using a Teflon piston. I always kind of struggle to use a Teflon piston. And that completes the procedure. So the tympanomeatal flap is reposited back, and a single or a couple of pieces of gel foam are just kept on the flap. So then we have some special situations. Many times we get cases in which a previous tapedotomy was attempted, and what had happened is that the incus was displaced. So once the incus is displaced, there is no way you can put a piston on it. You will have to put a maliovestibular prosthesis. So maliovestibular prosthesis is that, or in special other cases in which the incus has necrosed, it was a successful tapedotomy, but over the years the incus necrosed, and then you don't have any incus, and then you have to put the prosthesis on the malleus. It is an angled prosthesis, right? So it hooks onto the malleus and then gets inserted into the foot plate. So that's called an MVP, maliovestibular prosthesis. So the procedure is the same, raising the tympanomeatal flap as you would do with a routine stapedotomy. But in this case, the be separated from the tympanic membrane, and that is the tricky part, because it is the tympanic membrane is very densely stuck at the umbo. So many times there can be a tear when you are using a maliovestibular prosthesis. So you have to be little careful when you are elevating it. So what most of the surgeons do is that they don't separate the tympanic membrane from the umbo. They just separate the part which is not adherent to the, or not densely adherent to the tympanic membrane. They just lift it up, they incise just between the malleus and the tympanic membrane, raise up that, and then they put a maliovestibular prosthesis. Now, once the prosthesis has been put on the malleus, the tympanic membrane is going to touch the titanium prosthesis. So to avoid contact of the tympanic membrane with the prosthesis, we have to put a small piece of perichondrium over the prosthesis. So it makes it a little tricky. So we have raised the tympanomeatal flap. So now where the tympanic membrane is attached to the malleus. So using a sharp sickle, I'm separating that. I'm working on the malleus. You can see there is no incus. So either using a very sharp pick or a fine needle, you separate the the tympanic membrane from the middle part of the malleus. Don't try to separate it from the umbo. It usually doesn't happen. You will end up creating a perforation. So we have been able to lift it up in the middle part. And just a little opening that's created, that should be enough for the maliovestibular prosthesis to come into place. So in this surgery, this is the step that takes the maximal time. So that is the foot plate. And there we fire a shot, we can create a fenestra. A normal millimeter fenestra is created. This is the maliovestibular prosthesis. So I'll just show you. This looks like the normal prosthesis, but this has a ball joint on this area. So this can move forward or backward. So this will engage on the malleus and move forward, and it will form a 90-degree into the stapes. So first insert it into the opening and then gently rock it from the ball joint and engage over the malleus. And this is the ball joint. You can adjust its length by moving it up or down. So see how it forms a 90-degree here. And then a small piece of perichondrium is inserted over the prosthesis so that it is not in direct contact with the tympanic membrane. Otherwise, there'll be a perforation for sure. So just a small piece. And the tympanomeatal flap is deposited back, a single piece of gel foam is kept over it, and that completes the procedure. Okay, so we have had a share of complications in stapes surgery, but they were not laser related. Like it was not due to the laser. They were just complications that usually happen during the course of a stapedotomy. We have had perforations. You can see the titanium prosthesis inside, but look at this. There's a huge perforation. We had to do a tympanoplasty because the hearing had not recovered. And we have had displaced prosthesis, again, nothing laser related, but many times the incus gets necrosed or your crimping was inadequate or whatever, and the piston was shorter, it has come out. So literature surgery or managing any complication, a laser is recommended. So we had this case. It was a difficult stapes, difficult because there was a persistent stapedial artery, but we had picked it up in preoperative CT scan. There was a dehiscent facial nerve. And while we were attempting to remove the crura from the anterior part, the anterior crura became engaged in the persistent stapedial artery. And I used a little bit of, rather more force than what is required. And I ended up fracturing the foot plate. But because we had a laser, we had no issue in creating a fenestra and putting in a piston. So this is the persistent stapedial artery. You can see its exit into the middle ear. And right here, a direct branch from the carotid where you can see it coming out. And this was the case. So you can see a low-lying dehiscent facial nerve. And this white is the persistent stapedial artery running in the anterior part. So after the procedure is done, that anterior crura got stuck. Foot plate kind of fractured. You can see this mobility right here. There's a fracture right here. But we were able to fire a laser shot. Of course, no touch. So even if there is a fracture, there is nothing detrimental that is going to happen. And this is the persistent stapedial artery. And we were able to insert a titanium prosthesis. So see, advantage of doing a CT preoperatively and having a laser. Otherwise, if there would have been a fracture and I had conventional instrumentation, I would not have been able to create a fenestra because the foot plate was kind of mobile and it would have sunk in. So this was another revision stapes we did. The patient had a perilimb fistula, was referred to us. There was a displaced prosthesis and a fractured foot plate. So you can see the piston was off again. Beautifully, this loop, it was completely off the incus. And see this soft tissue looking in the foot plate area. This is always significant for a perilimb fistula. If you see this in the foot plate area should be black, there should be air. But if you see this soft tissue and the patient is having vertigo, this is how a perilimb. So that's marked by the yellow arrow. And there was a part of bone chip which had gone inside the vestibule. We did not try to retrieve that. So procedures started again with a radial incision like I had described, then join it with a circular knife. Raise the tympanomeatal flap. And you can see the perilymph leaking out. The posterior superior overhang had not been completely taken out. The piston was lying free off the incus. We retrieved it. And you can see the fracture here. we revised the stapedotomy opening and we put in a fresh piston. And we sealed that area with a little bit of fat. This I'm doing the bend test. And now I've sealed it with fat. The tympanomeatal flap was reposited back. So this was another revision stapes which done. Again, adhesions. So same, the piston is not completely in the foot plate. Do you see this? The foot plate is here. The piston should actually be going beyond it, but it was resting on the foot plate. So that's why the patient had a conductive loss after surgery. So look, the piston is entrapped in adhesions and it has probably got pulled out from the foot plate area. So see, that's the lower end of the piston. It is not in the stapedotomy opening. That's the facial nerve. The foot plate is here. So it had kind of come out and was resting on the foot plate. So we went ahead and using again the carbon dioxide laser, we lased out the adhesions. Advantage of using a laser is, on these adhesions is that there is no bleeding. So your field absolutely remains clear. Out the adhesions. Gently using, a pressure with the suction, pushing the tissues away, creating a plane for the laser to go through. So once that is done, we remove the older piston, fire a fresh shot. There are adhesions on the foot plate area. We are removing that. And separating the lower end of the piston by removing those adhesions, because that lower end is stuck onto the foot plate and you don't want to pull it. Then separating the top end and then gently freeing the older prosthesis. So once that is done, we will create a new fenestra. There, a new fenestra is created and we put in a fresh piston. There. So that completes the procedure. I don't remember why I put this small piece of fat there, because normally we don't. Or maybe it was just to seal off the previous fenestra which could be around that area. And same tympanoflatal flap is reposited back and a piece of gel foam is put. Then special situations, obliterative focus. Again, it was picked up preoperatively on the CT scan. Now look, this is the crura. That's the foot plate area, and look how thick the obliterative focus is. Now everyone, you have to understand when there is an obliterative focus, the length of your piston used would be longer. So make sure that you have that at the back of your mind once you drill out the obliterative focus, because the obliterative focus kind of goes inside. So by the time you reach a blue line, you will be 0.5 or 0.25 millimeter deeper than what you would be in a normal stapedotomy. So a longer prosthesis has to be used. So do you see this white obliterative focus? That is what it looks like. And once you start drilling it, it is going to bleed. But once the bleeding stops, when you are drilling it, it means you are on the verge of blue lining it. Then you stop your drilling. That should be your indication, because initially when you start drilling obliterative focus, there is going to be a lot of bleed. Once the bleeding reduces, that means you have reached your limit, because it is the orthoscopic bone that bleeds. Once you reach the normal foot plate, the bleeding will automatically stop. So that should be as a as a sign to you that you are reaching the limit of your drilling. So you can see the complete obliterative foot plate. I do a tenotomy with a laser. Then I fire a few shots over the surface just to kind of laze away the mucosa. So this firing the shot will not create a fenestra. We use plates with a moza. Now I'm using a skeeter with a 0.6 millimeter diamond burr. You can see the facial nerve on top. And as soon as the drilling starts, you will see how the bleeding comes in. But you have to be patient. This bleeding stops very easily with the adrenaline soaked gel foam. Once there is bleeding, suction it or put a piece of gel foam, wait for a few seconds. And it has to be done gradually. Many times your skeeter is going to continue touching the incus. Be very careful that you don't displace it. So see, the bleeding has reduced, but you have still not been able to blue line it. And don't create a well. You have to go in wide. So a minimum, at least 40-50% of the foot plate, drill it out. So skeeter is nothing but a very fine micro drill, which with an angled head. So your hand stays out of the way. It is low torque. So once you blue line, then I've blue lined it and skeeter. So at low RPM, we have created a fenestra and we have drilled out the orthoscopic focus. So see how there is no blood around. So make sure that your field is absolutely clean and you don't have blood going into the vestibule. We instill some amount of steroid. And we had to use a Teflon piston because I did not keep this in mind that, it is an obliterative focus. I would need a longer piston. No one had ever taught us this. Our titanium course piston was 4.25 millimeter and the length which we measured was 4.75. So we had to take out a Teflon piston, cut it to 4.75 and insert that. So then we come to chorda tympani management. This is a question which, again, like I would say, we would get asked by our students or at conferences that taste disturbances, what happens to the chorda tympani, how do you manage it? Do we stretch it? Do you cut it? So there is a lot of noise over chorda tympani, but for beginners, you have to understand that the purpose of the chorda tympani, I mean, if you can preserve it, nothing like it, but if it is coming in your way and it is going to hamper you inserting a piston and create a complication like a fractured foot plate or a submerged foot plate, it is better to cut it out and get it out of the way so you have adequate white space and you can continue with the surgery comfortably, right? So these are some of the articles. This is an original article which concluded that symptoms appearing after iatrogenic damage to chorda tympani nerve have in general little clinical relevance, especially in the long term, regardless of whether the nerve is dissected or manipulated to various degrees. So it says in the long term, it really doesn't matter. After a few years, the patient is not going to have any, taste disorders. Whether you have cut it, dissected it, or stretched it, thoda stretch kiya, zyada stretch kiya, it is not going to matter. And these are another of the few studies in which that long term, there are no significant differences between patients in whom the chorda tympani was preserved compared with those in whom the chorda tympani was sacrificed during surgery. Right? So the percentage is, very less of patients who would actually come and complain to you that, I'm having some taste disturbance. There's another study which was between the free beam, that is the fiber which I showed, and a micromanipulator laser delivery. Again, it concluded that operating times were shorter using the fiber, but outcomes are the same. So it doesn't really matter, like I said in the start, whether you use a fiber system or you use the micro manipulator. In good hands, both of them deliver equal results. So this is another systematic review, which was published in the American Rhinological and Otological Society journal. The laryngoscope. Okay, so why is it important? Because we also do get asked that why do you think laser is better, or is laser actually better than the conventional instrumentation? So this systematic review concluded that both footplate fractures and sensorineural hearing loss appear to occur more frequently in the conventional group than in the laser group. Of course, why would a fracture occur more, or why would the footplate get submerged? Why would there be more chances if you're using a conventional group, that is conventional cold instruments? Of course, the reason for that is because you are touching the footplate. So what are the steps that things go wrong in? Tympanomeatal flap, posterior superior curating or drilling really doesn't matter. You can do it very well. The problem occurs when you are creating that fenestra or when you are fracturing the posterior crura. That is where when the footplate can get mobilized, when you are fracturing the posterior crura, and it can fracture and sink in when you are trying to make a fenestra. So these two steps of the touch of the instrument are eliminated when we use a carbon dioxide laser. So that is why, of course, the complication rate of, with a CO2 laser, you're not going to have a submerged footplate or a displaced footplate. So just a few tips: start with simpler cases and have a senior colleague mentor you and stand with you, right? If you see the footplate has been mobilized, then stop. There is still hope. So in initial stages, what happens, if the footplate gets mobilized, don't do anything heroic. Stop, close the tympanomeatal flap, counsel the patient, I'm going to re-explore you in 3 to 6 months. In 3 to 6 months, the footplate is going to fix again. You will get another chance. But if it is mobilized and you are attempting to, unless you have a laser, of course, and you are attempting to make a fenestra, that there is either going to be a fracture, or the footplate, since it's mobilized, is either going to come out completely, that is going to get submerged into the vestibule. We don't want that to happen because they will not lead to ideal outcomes. So stop if you see if you mobilize the footplate, come back again 6 months later. We get asked, is doing under general anesthesia okay? It's absolutely okay. If you are comfortable with it, and in the starting, it's going to take you more time, you're worried the local anesthesia will run out, go ahead, do it under general anesthesia. There is, it's GA is very safe nowadays, and it's an absolute okay to start with general anesthesia. And we do the first audiometry in 6 weeks, then 3 months, then 6 months. Don't start doing audiometries the second day or the third day or the fourth day. The tympanomeatal flap is not settled. There is a lot of perilymph ooze in the middle ear. The things have not fallen into space, and you might get depressed that, oh, the AB gap has not closed. It's not going to close in 2 days, 3 days, right? Give the healing time and give it at least 6 weeks, and then do a audiometry. Thank you so much.
Thank you very much, sir. Thank you, sir. So, first is that if any of you have any questions, you may please put on there. As sir has said that this bone curettage is a simple thing, but I would say that when you are starting your procedure, first thing is that before you yourself do it, you should be very keenly observing your mentor or a surgeon, your senior, for few cases, and you should see the hand movements. That's the most important thing, that you should keep a watch on your screen, what you are seeing inside, and also you should be seeing that how the instruments are being held by the surgeon, and how the movements, at what level the movements of the instrument is happening. So most of your movement should happen at the level of the wrist, not at the level of the hand or the forearm. That's most important. And when you are doing the curettage, so there are two ways to remove the bone, and I've seen both the surgeons, a few people actually prefer to thin out the overhang and then curettage it with the bone curate, and few people would curate all with the with the bone curate. So curate. So this is an important thing, that your instrument should be very fine if you are doing it with the cold instruments, and it should always be from superior to inferior, so that you do not displace the incus. So I think all of you would have learned that when you have assisted your seniors doing STPs. Few questions, sir, I would like to ask.
Sure, sure.
What is the what is the limit of facial prolapse when you would say no?
So it again depends on a clinical skill.
Yes.
If we have even we have even in a very narrow niche, low-lying descent facial nerve, we have drilled out part of the promontory and have been able to insert a piston. And we were worried that that piston is going to, because what, see, these are all stories what we had heard, that piston should not be touching the facial nerve, and because it's going to cause a paralysis. But surprisingly, nothing happened.
Doesn't happen, sir.
You know, and the same thing with the round window otosclerosis. Your hearing would be okay. We did a CT, we had round window otosclerosis. We went ahead and did the surgery. Patient had no benefit.
Yeah.
So, I mean, these are the things you learn along your journey of the stapes surgery. And many of the things you will realize were just stories which were told to you without any actual experience.
The next is, sir, where should your site of fenestra should be?
Okay, again, it depends upon what kind of anatomy you encounter. If there is a low-lying facial nerve and a narrow niche, your fenestra obviously can't be posteriorly. It has to go slightly anteriorly. And it really does not matter whether it is in the middle or posteriorly. Some literature tells us that the posterior part is the best. New studies have shown us that the middle part is the best, because that is the part where the utricle and the saccule are furthest away from the underside of the footplate.
Okay, so
and half a millimeter here, half a millimeter there, I don't even think we can, kind of judge that.
The more important thing is that preferably your so that is, I think,
but anatomy will change that. Many times low-lying descent facial nerve will come across the posterior part. You will be forced to make the fenestra a little ahead.
So one thing which I could see in all of your presentation, that we didn't see you measuring the piston or the length of the piston.
Right. Okay, so that step number one, because for the coarse titanium process, there's a special measuring rod which we use. I had not, I've not kept a video of that. Actually, I should have shown that rod. That is number one. Number two, again, it's a personal thing. I mean, don't quote me or anything. With experience, you can actually get an idea of what size of piston are you going to choose, right? Many surgeons say that have a few sterilized pistons and just check it, because that is the best way for the piston to go in. With a titanium, you can't cut that piston. It is either 4.25 or a 4.5 or a 4 or a 4.75. And go ahead, put in a piston. If you feel it is shorter and it is coming out, change it, put a 4.5. Now, does putting a 4.5 matter? I don't think so. I mean, now if you tell me that I have used a 4.3723 mm piston and my results are better, I really don't know, right? The thing should be that the piston should not be short. It is the short piston that causes the damage, because there are a lot of articles, I haven't shown those, but what happens when the piston is short and it's moving, it pops out of the stapedotropy opening and comes to rest onto the footplate, like that revision case which I showed you. Now, once it is resting on the footplate, the sound conduction is still happening. There is still some movement in the piston. The piston continues to move and it starts eroding the incus. So there are many articles in literature which shows that this is why the incus gets eroded, because the piston is short, it has come out of the hole, it is resting on the footplate, conduction and the force transmission is still taking place, and the underside of the incus gets eroded. So a 0.25 mm longer is not going to cause any harm, right? Patient says, oh, surgeon say I put in a long piston, it caused vertigo. Well, for it to touch the utricle saccule, it needs to be, normally used. So if you're using a 4.25, तुमने 6 mm का piston डालोगे तब patient को problem आएगा. Right? And I don't think so, any of us have heard on that size of a piston. So again, matter of experience. Why I find it very, in my initial stages, trying to take in the measuring rod, one of the prongs used to engage in the incus. When I used to pull it out, I used to end up moving the incus. I don't know if it has happened with you, but at least it has happened with me in the beginning. The course measuring prosthesis is very simple. It's a retractable kind of tool. So you keep it onto the incus and you take it out. The retractable part moves downwards, touches the footplate, and you get an idea.
Yes, sir. That we have also found that that's the best measuring rod to be used actually.
Exactly. So तेरे से कभी अटका है the normal measuring rod का prong into the incus?
नहीं सर, अटकता है वो बस.
अटकता है, सबसे अटकता है.
And then again, sir, it is like, मतलब it's when you go in and then that three-dimensional actually which of the 3-4 things which we were using earlier,
right?
So which is actually the right length is, again, it's like not very easy. With the course one, it is very simple and straightforward.
Yeah.
You just take it out and measure it on the jig and then take the same processes.
Absolutely. And then just open it. And don't be afraid to open another one. अगर तेरे को दिख रहा है कि छोटा है, उसे change कर दो. That is the time you get. Don't hope that it will get entrapped in the new membrane and it will not come out. It will come out.
Yes, sir. So, sir, from the delegates' parts, they want to know that are there any specific post-operative advices after a stapedotomy?
So again, I think post-operative advice for stapedotomy patients has been overhyped. Bed rest, don't move, your piston will come out, right? It doesn't happen. I mean, if the piston is clinked on and moving, so we have turned it into a daycare surgery. Stapedotomy is a daycare, and even in the best centers, it is daycare surgery. So don't keep your patients admitted for 5 days, 7 days, 10 days. We give an intra-op shot of an antibiotic. After that is having vertigo post-operatively, then something can be added for that. Again, that will depend, because many times on the first attempt the piston doesn't go in, and then you many times have to suction out the blood and some of the perilymph gets sucked out. All those things can cause post-operative vertigo. So just to settle the patient, though we tell them not to do heavy work.
Yes, sir.
Right. Other than that, I mean, they can walk around, lay in bed, sit on the table and eat. I mean, nothing is going to happen.
And what about the situations where their ear is exposed to the negative pressure, like the air travel and all?
Flying, again, I have not found a right answer. If you tell me 23 days is what I will make the patient fly after, or 30 days, ये सारा arbitrary है.
Yes, sir.
Some surgeons say they come to me from this place and they are flying back in the first week. Some say 6 weeks, some say 3 weeks. So for me, I have just taken a average of everything of what I heard when we were learning stapes. So 3 to 6 weeks, no flying.
Yes, so that is important, that because that is not in our control. I advise them that at least for 4 weeks they should not be flying.
Yeah. So वो 4 week better है, 3 हफ्ते better है, 2 हफ्ते better है, वो किसी को नहीं पता. We don't know. But just play safe. I mean, I really would not know what would happen अगर piston की length ठीक है, सब कुछ बढ़िया है, तो cabins are pressurized. I don't know what's going to happen if they are even flying in the first week. Because if you speak with Robert Vincent, I mean, he does a lot of international patients who fly in. He says, I send them home in 48 hours. They can fly back. So again, it is different for, it depends on your practice, whatever you are comfortable with. In medicine and surgery, there are many things, many times there is not an absolute answer. There is always an average. So stick with 3 to 6 weeks. I mean, it's not that you have operated upon the, the prime minister of the country that he has to fly out immediately. I mean, people can wait 3 weeks post-operatively, 4 weeks until it's a thing. So for me, 3 to 6 weeks. Yes, two of my patients. So, and we don't know why it happened. And the second patient, she was a young patient, 23-year-old. I remember, एक साल किया था बिल्कुल बढ़िया. She had come for the second year. Second year we did, and next day she comes tinnitus, inability to hear anything, and we put her on steroids, but nothing. The hearing loss did not recover.
So is it beneficial to seal the fenestra with the muscle piece?
So what happens in laser, the opening and the piston size with the titanium is so precise. So there's a 0.4 piston and a 0.5 millimeter opening you have created. I have not sealed the fenestra ever in my cases. I mean, me and Vikas have worked together. He knows. I mean, we never used to seal the fenestra.
Thank you.
So I think this fat thing comes mostly when like we are doing it with the conventional instruments, and then initially what we do is that we find that our fenestra is not big enough to accommodate the lower end of the piston, and then there we use a very sharp pick to how it is going easily, but it is a bit larger. So these are the cases where we would, for our own peace of mind, we would like to use the fat. But most of the people, or like we ourselves also, we do not use fat. What we maximally do is that whatever the blood is around, we will just let it go there and just
Seal it.
settle down. The blood will seal it.
Okay.
But that should be after you have put in the piston.
Okay. Thank you, sir.
What we conventionally see when I was resident, so at that time that's just only this skeeter was just coming in. So most of the cases which I did see or I assisted with my teachers were with the conventional instruments. So they would routinely do what they would do once they have put in the piston, they will just slightly scrap the nearby mucosa and let a drop of blood come in and just then deposit the flap.
Correct. And the other indication which I showed, I did a perilimb fistula. That is the case in which you covered it with fat.
Think, sir, if you can just show your first slide where you have numbered the steps. So all of you should see that slide and work on those steps one by one and what works best for you. So when you are assisting, you just memorize the surgery in those steps 1, 2, 3, 4, 5, 6, which sir has shown. So that would make you improve step by step in all the facets of this very wonderful surgery. And one more thing which sir said that because when there are many people in the circuit who would say that no, you should always be doing it under local anesthesia because only then you will know that whether your hearing outcome is good or not. I would say that as sir has said that in whatever way you are comfortable, you should be doing, and especially when you are starting this surgery, I would always suggest that please do it under general anesthesia. The most important thing is that you should be knowing that your piston is not short, that which sir has also emphasized. So if your piston length is good, your patient is going to be benefited. It is not that when the person on the table says, even in GA, in the later part of my residency, I was trained in with Dr. PP Singh, and he would routinely do most of his surgeries under GA. And the results were always very good, because sir will check that yes, the length of the piston is the most important thing. That it should be properly in. It should not be short. And even if it is a bit longer, and maybe in the coming morning patient would say, or there is a bit of nystagmus, believe me, it will settle down in a day or two.
Correct.
It all settles down. And these patients will be the patient where you will actually will have a very good closer.
So I got asked this question at the Amritsar conference, the Orient Vikas Robert and Satish ke saath jo hua tha.
Yes.
That you are doing it under GA, you will not be able to assess the hearing, what you have asked, right? So you have diagnosed it as autosclerosis on a preoperative CT. You have seen the focus, you have created the fenestra, you have put in the piston, your crimp is proper. Why will the patient not hear?
Yes.
हो गया, whether you are in G or LA, तुम कुछ नहीं कर सकते.
कुछ नहीं कर सकते.
That is not going to change. And in that quiet OT environment, when you ask the patient to say 1, 2, 3, I think that's the biggest fraud. Suction machine बंद, monitor बंद, कोई resident ने बोलना नहीं, किसी ने सांस भी नहीं लेना. वो अगर patient जब autosclerosis उसे हो भी तो भी सुनेगा वो उस environment में. I mean, in that quiet OT environment, सबको सुन रहा होता है, मतलब उसको दूसरे कान से भी सुनता है.
Yes,
इसको अभी ऑपरेट भी नहीं किया. So your comfort and how to perform the surgery to perfection is more important than what anesthesia you are using. Immediately, like I said, लोग कहते हैं कि 2 दिन बाद ऑटोमेट्री करा दो. यार अभी तो TM flap भी elevate नहीं हुआ. Many of you have filled the EAC with gel foam, put a cottonoid आगे, उसका ऑटोमेट्री करा के क्या गेन होगा? अंदर पेरीलिम्फ है, ब्लड है, मोबिलिटी अभी पूरी आई नहीं है. The body is just settling down, healing. So what will you gain in a saying that कि 2 दिन या 4 दिन के बाद audiometry? Give the body time to heal, give everything time to fall in place, let all the new membrane form, and आराम से 6 हफ्ते में करवा लो. Hope you can't do anything else. Once it has happened, you have to give steroids and hope for the best.
So any more questions from the delegate side, or should we close the session? Dr. Utkal, should we close? Chalo, thank you, sir. Thank you very much, sir. Thank you all the delegates.
And thank you for
Thank you, sir.
gently.
Dr. Sajal is saying something. चलिए सर, thank you.
Thank you, Vikas. Have a good Sunday. Bye bye. Take care.
Bye bye, sir. Bye bye.